Welcome back to this next video in which we are studying headaches. Okay, so we have now finished our discussion of the pathophysiology that underlies cluster headache, and we now want to move on and discuss the treatment for cluster headache, both the abortive treatment and the prophylactic treatment. However, before we do that, let me just, for one last time, summarize the pathophysiology underlying cluster headaches, or what we believe is the pathophysiology underlying cluster headaches. So, if you suffer from cluster headache, this disorder of being susceptible to suffering from cluster headaches, we have discussed that this means that your hypothalamus is susceptible at certain times of the year and at certain times of the day at those times of year to this hyperactivity phenomenon which occurs in one of its two sides, and it can occur on different sides at different episodes. Now, it is this hyperactivity phenomenon that then gives rise to the cluster headache, and the way that it's believed to do it is by activating the ipsilateral trigeminocervical complex. So if it was on the left-hand side, as indeed is shown on this picture, it will activate the left trigeminocervical complex, and this is the reason that it gives rise to an ipsilateral cluster headache. So in the trigeminocervical complex, it will activate the second-order neurons which receive input from primary nociceptive afferents from the frontal region, the periorbital region, and the temporal region. And this means that when those second-order neurons are activated, you will get unilateral pain on the side of the hyperactivity in the hypothalamus in the frontal, periorbital, and temporal regions. And this pain will be extremely severe because they are capable, the hyperactivity is capable of activating these second-order neurons to fire extremely rapidly, and therefore the pain is described as severe and stabbing. And it can last between 15 minutes and 3 hours because that's how long the hyperactivity in the hypothalamus presumably can last for as well. Right, so there's where the headache comes from. Now let's talk about accompanying symptoms. We understand nausea and vomiting extremely well. When the cerebral hemispheres are experiencing pain, there are pathways that are not well understood, linking them down to the reticular formation vomiting center, and they can activate the vomiting center, and depending on how much they activate it, you'll either feel nauseous or you actually vomit. There are no meningeal symptoms usually, and that of course is because there is no activation of the meningeal nociceptors. We have bypassed meningeal nociceptors. So, unless you have activation of the meningeal nociceptors, you do not get the meningeal symptoms. Of course, we can say that as a nice, easy rule to learn, but of course we don't really understand the pathway by which that actually occurs, because of course the primary nociceptive afferents from the meninges synapse onto these same second-order neurons that we are now activating. So how on earth does the brain know precisely when the meningeal nociceptors are activated? We don't know is the answer, but somehow it must be able to know when the meningeal nociceptors have actually been activated, and here they have not been activated, and therefore you do not get the meningeal symptoms. We've bypassed the meningeal nociceptors. Okay, even though we don't quite understand the mechanism by which you get meningeal symptoms only when the meningeal nociceptors are activated. Then on to the autonomic symptoms, which are very, very important for us to understand. These, again, we believe result from the activation of this half of the hypothalamus, the hyperactivity here, this epileptic-like activity. Remember, the hypothalamus is a control center for the autonomic nervous system. The left hypothalamus controls the left autonomic nervous system, and the right hypothalamus controls the right side of the hypothalamus, I should say, rather than right hypothalamus. The right side of the hypothalamus controls the right autonomic nervous system. So, overall, the autonomic changes that you're going to get are increased parasympathetic activity to the ipsilateral eye and decreased sympathetic activity on the ipsilateral side. So, increased parasympathetic activity is achieved by the activation of the ipsilateral left, in this case left, Ergot-Alkaloid nucleus and superior salivatory nucleus, and those, when they're activated, will produce miosis in the case of the Ergot-Alkaloid nucleus, and lacrimation, rhinorrhea, and a red eye in the case of the superior salivatory nucleus. Somehow then, this hyperactivity in one of the sides of the hypothalamus will then lead to the inactivation of the sympathetic innervation to the ipsilateral eye as well, orbital cavity, and this will lead to also miosis, but also the ptosis, the droopy eyelid on the side that is affected by the cluster headache. And then finally, we discussed why cutaneous allodynia can occur. It's because when you're frequently suffering from cluster headaches and you're frequently getting the activation of these second-order neurons in the trigeminocervical complex, those second-order neurons can become sensitized, and now the primary nociceptive afferents from the peripheral tissues can activate them more easily, and therefore stimuli that should not be transmitted to the second-order neurons and therefore should not normally cause pain can now be transmitted and will cause the sensation of pain. So, there's the summary of the pathophysiology. Let's now talk about treatment, and of course we will start off by discussing abortive treatments. I'll just put a little title here. We're going to discuss abortive treatments. So NSAIDs are not really effective for cluster headaches, and we can understand why. Where has prostaglandin E2 featured in my mechanism? Absolutely nowhere. So why would giving NSAIDs or paracetamol drugs that stop the production of prostaglandin E2 be helpful? The answer is they're not. So abortive treatments for cluster headaches does not include NSAIDs and paracetamol. One of the really very effective abortive treatments for cluster headaches that we've never seen so far for any of the other headaches is breathing in 100% oxygen. So I'll put this just here. 100% oxygen I'm going to put right at the top of the abortive treatments because it is incredibly effective. If someone is currently suffering from a cluster headache, what they can do is they can get an oxygen canister, which they've been given to them by their doctor, and they'll have a tube from the oxygen canister that will then go into their nostrils. It will have two nostril pieces that will blow the oxygen into their nose, and then it can then breathe in the 100% oxygen. And they need to have the oxygen coming out of the canister at a reasonably high flow rate, and the flow rate that's generally advised is between 7 and 10 litres per minute. So that means 7 to 10 litres of oxygen is coming out of the canister per minute, and they will be breathing that in. Now, breathing in this 100% oxygen, goodness knows how it works, but presumably somehow it must stop the hyperactivity that is occurring in the side of the hypothalamus that is on the side of the cluster headache, and therefore it aborts the cluster headache. It is incredibly effective. Breathing in 100% oxygen is incredibly effective at aborting cluster headaches, and indeed we give oxygen canisters to people who are suffering from cluster headache so that they can abort. Well, some people get this if they want it, so that they can abort their cluster headaches, and it is extremely effective. Okay, right, now let me talk about other options for aborting cluster headaches. So other options, think back to the drugs that we saw in the case of abortive treatments for migraine. We talked about the triptans and the ergot alkaloids, which were 5-HT1B, 1D, and 1F agonists. And remember, 5-HT1B and 1D, those were on the meningeal nociceptors, and activating those was good at stopping the activation of the primary nociceptive afferents from the meningeal nociceptors and stopping the release of the neurogenic inflammatory mediators, calcitonin gene-related peptide and substance P. However, that's obviously not relevant here, but the 5-HT1F receptor, that was actually on the surface of the dendrites of the second-order neurons in the trigeminocervical complex, and activating that on those second-order neurons was capable of inhibiting the second-order neurons. Inhibiting the second-order neurons here would be very helpful, because then the hyperactivity in the hypothalamus might not be able to activate them as much, and therefore you might get some relief from the headache. Maybe you won't get any relief from the autonomic symptoms, which are also being caused by the hyperactivity in the hypothalamus, but at least you should get some relief from the headache. So 5-HT1F agonists should be effective, so I'll just put this here. We are interested in these drugs that have 5-HT1F agonist properties because they can inhibit the neurons in the trigeminocervical complex. And of course, examples of 5-HT1F agonists are all of those triptans, and can you still recite all 8 of them back out to me? Let's see if I can. Sumatriptan, rizatriptan, naratriptan, zolmitriptan, amitriptan, almatriptan, elatriptan, that's 7. What's the final one? And then have I done frovatriptan? I don't think I have. That's the 8th one. So those are the 8 triptans. Remember, they're not just 5-HT1F agonists, they're 5-HT1B, 1D, and 1F agonists, but the bit that's important here is that they're 5-HT1F agonists. And then the other drugs that we saw earlier on, which are indeed 5-HT1F agonists, are the Ergot Alkaloids. I remember the two examples of ergot alkaloids that we saw were ergotamine and dihydroergotamine. They were again 5-HT1B1D and 1F agonists, but the bit that's relevant here for them aborting cluster headaches is that they are 5-HT1F agonists. So these 5-HT1F agonists, both the triptans and the ergot alkaloids, they can be used for the purpose of aborting cluster headaches, and they are reasonably good at providing some relief, at least from cluster headaches. They might not get rid of it all, but they will get rid of some of the pain of a cluster headache. The 100% oxygen is absolutely fantastic. It's very, very good at aborting the entire thing. Of course, they will get rid of the pain, but will they get rid of the autonomic symptoms? Well, no is the answer, because they're not stopping the overactivity in the hypothalamus, they're stopping the overactivity from activating the second order neurons. They're not going to stop it activating the heading of S-val nucleus and the superior salivatory nucleus and inhibiting the preganglionic sympathetic fibers that are going to innervate the orbital contents. So it won't get rid of all of the symptoms of the cluster headache, but it should at least provide some relief from the actual pain. Okay, so those are the abortive treatments for cluster headaches. Let's now talk about prophylactic treatments. So I'll write this here. So now on to the prophylactic treatments. So now again, we're going to see a whole bunch of drugs that we haven't seen previously. The prophylactic treatment for cluster headache is again very different from what we've previously seen for tension type headaches and migraine headaches. Okay, so prophylactic treatment for cluster headaches. You can use glucocorticoids. They are effective at reducing the chance that you will actually suffer from a cluster headache. And of course, all of these prophylactic treatments that I'm about to go into to prevent you suffering from a cluster headache, somehow these drugs must actually reduce the chance that in the hypothalamus this phenomenon, this hyperactivity, will actually occur. So all of these drugs somehow, even though we don't particularly well understand their mechanisms, somehow they must reduce the chance of this hyperactivity phenomenon occurring within one side of the hypothalamus, and hence must reduce your chance of suffering from a cluster headache. So glucocorticoids can be used for this, and therefore they must somehow reduce the chance that in the hypothalamus this hyperactivity phenomenon will occur. So the list part then, let me list off some examples of glucocorticoids. Let's have a nice colour for this. So how many examples can I come up with of glucocorticoids? So of course a major one is prednisone. Now, prednisone is a prodrug. It's not the final drug. Prednisone is taken, it will go into the bloodstream, and then it will go to the liver where it is converted into the active drug, which is prednisolone. Now, you can also give prednisolone directly, so sometimes prednisone is prescribed, which is the prodrug, and sometimes the active drug, prednisolone, is prescribed instead. They do exactly the same thing. This is just the prodrug. This is the final drug that will actually have its effect. So you can either give this one and it can be converted into this one, or you can give this one directly. Then an analogue of prednisolone is also sometimes used, which is methylprednisolone. So I'll write this one down. So methylprednisolone, so it's a slightly modified version of prednisolone that's still going to have glucocorticoid activity. More glucocorticoids, hydrocortisone is of course a very important one. Hydrocortisone. And then I've got two more examples, dexamethasone and triamcinolone. So dexamethasone and triamcinolone. And after we've written down all of their names, we'll then have a look at a little bit about their mechanism of action. Of course, I'm not going to be able to give you a complete explanation as to how they somehow stop this hyperactivity occurring in the hypothalamus, because we don't understand what generates that, but I can tell you a little bit about their mechanism. So, here are some examples of glucocorticoids. Prednisone, which is the prodrug for prednisolone, methylprednisolone, which is a slight modification of prednisolone, and then hydrocortisone, dexamethasone, and triamcinolone. Okay, so all of these drugs are glucocorticoids. They will go into cells, they will cross the cell membrane, they will then go into the cytoplasm, and they bind to a receptor in the cytoplasm called the glucocorticoid receptor. So let's just draw their mechanism to the side here. And so, let's have this in purple here is the plasma membrane, the cell membrane. So here is the plasma membrane. Let's now draw on the glucocorticoid receptor. So here is the glucocorticoid receptor, and for short, I'll abbreviate it down to GR for short, glucocorticoid receptor. Now, normally the glucocorticoid receptor is not active, and it has another protein bound to it, which I'll draw in light green here, and that protein is HSP90, which stands for heat shock protein 90. So H and S is for heat shock, then the P is for protein, and then the 90 I would imagine is the weight of it, 90 kilodaltons probably. So, or thereabouts. So normally the glucocorticoid receptor, you have loads of these glucocorticoid receptors in the cytoplasm of the cell, and they're usually bound to this protein that inactivates them called the heat shock protein 90, so that they don't usually do what they're capable of doing. Now, if the glucocorticoid comes along, so what colour should we have the glucocorticoid in? So we'll have it in red here. So glucocorticoids, they're all very hydrophobic, so they can cross the cell membrane nice and easily. So here it comes, it crosses the cell membrane. This is our glucocorticoid, so I just abbreviate it to G. And what it does is it binds to the glucocorticoid receptor and causes the heat shock protein 90 to detach from the glucocorticoid receptor. So what you will end up with then is now this will come and bind here, and what you will end up with is a glucocorticoid receptor, like so. So capital GR here, and then here is the glucocorticoid bound to the glucocorticoid receptor. Now, once the glucocorticoid receptor has the glucocorticoid drug bound to it, it then moves into the cytoplasm of the cell. And I should probably just give you a little bit of motivatory background. Remember, all of these drugs are analogues for a natural molecule in the body, and the natural molecule is actually hydrocortisone, although it's not usually called hydrocortisone. When it's produced by the body, we call it cortisol, and it's an important steroid hormone in the body. So this mechanism that exists inside all of our cells, this is really for the hormone cortisol, and all of these drugs are just abusing this pathway, basically. So obviously we do give cortisol, the real hormone, we just call it something different, hydrocortisone. These other ones are analogues of cortisol, and they can also use its mechanism here. So we are hijacking a mechanism that is endogenous to the body here. You might be wondering, why on earth do all of these drugs have their own pathway inside cells? No, this pathway exists for an endogenous hormone, cortisol, and we're now just giving something to activate that pathway inside of cells. Okay, so glucocorticoids, when you give them, they're going to go inside loads of cells in the body, and they're going to activate the glucocorticoid receptors like so. And once they've activated the glucocorticoid receptors, they're then going to move into the nucleus. So this in red can now represent the nuclear envelope. So I'll just label this up. This is the nuclear envelope, so it's going into the nucleus now. And once the glucocorticoid receptor complex is inside the nucleus, it will then dimerize with another glucocorticoid receptor complex. So let me draw this here. So here is one of these complexes dimerizing together. So here are two glucocorticoid receptors dimerized together, and now each one of them has a glucocorticoid bound to it, so that you make this dimer here. Now, this is what will actually function inside the nucleus. Once you've formed one of these dimers, this is actually going to do something. And what does this do? It changes gene expression. This is a transcription factor, this dimer of glucocorticoid receptors with glucocorticoid molecules bound to it is a transcription factor, and it's going to change the expression of loads of genes. So this is going to changes gene expression, and therefore can hugely change the behavior of cells. By changing what proteins are actually going to be produced in cells, you can hugely change the behavior of cells. And this is a mechanism that occurs all over the body. So cortisol is a very powerful hormone. It goes into cells all over the body and is going to activate the glucocorticoid receptors, which will become transcription factors. Firstly, of course, they have to translocate into the nucleus once the glucocorticoid is bound, and then they dimerize together to actually bind to DNA and change the expression of loads of genes inside the cell, and then they can change the cell's behavior hugely. And they're going to do this to loads of cells all over the body. So I've gone over this mechanism to try and give you some idea of what might be happening here. So if we give glucocorticoids to someone with cluster headache, it's going to change gene expression inside of cells all over the body, and we can imagine that this includes cells in the hypothalamus, and that by changing gene expression in the cells in the hypothalamus, somehow that might lead to a reduced probability that this phenomenon of hyperactivity will occur within the hypothalamus. So that's my sort of kind of explanation as to why these might work to reduce the chance that hyperactivity is occurring. They have an effect on loads of cells around the body by changing gene expression, so potentially they can change the gene expression in these hypothalamic cells and then lead to reduced chance that this hyperactivity phenomenon will develop, maybe. So there's an attempt at an explanation of that. Let's now have a look at the second type of prophylactic treatment for cluster headaches, and there's only two that I want to discuss here. Glucocorticoids can be used as the prophylactic treatment for cluster headaches, and then there is one other drug that is fantastic for prophylactically treating cluster headaches, and this is a drug called Verapamil. And this is the final drug that I'm going to discuss for the treatment of cluster headaches. So, Verapamil. What is the mechanism of action of Verapamil? You might have heard of it before. It is a use-dependent, and now you're probably expecting me to say voltage-gated sodium channel inhibitor. I'm not. It's a use-dependent voltage-gated calcium channel inhibitor, or a use-dependent got a little carried away. A use-dependent voltage-gated calcium channel blocker. So, this is going to do the exact same thing as use-dependent voltage-gated sodium channel inhibitors, except it's going to do it to L-type voltage-gated calcium channels. And in fact, maybe I should now put in there use-dependent L-type voltage-gated calcium channel inhibitor. So this thing, just like all of those use-dependent voltage-gated sodium channel inhibitors that we discussed, and the two that we actually gave examples of were topiramate and valproate. This is now capable of binding to voltage-gated calcium channels when they are in the open state and when they are in the inactivated state. So, voltage-gated calcium channels are exactly like what we've discussed for voltage-gated sodium channels. They have those three states as well: the closed resting state, the open state, and the closed inactivated state. And being a use-dependent L-type voltage-gated calcium channel inhibitor means that you can do exactly what a use-dependent voltage-gated sodium channel inhibitor does to voltage-gated sodium channels, but to voltage-gated calcium channels of the L-type. So that's what Verapamil can do. It can bind to the open and the closed inactivated channel, and it prolongs the amount of time that it will take the channel to return from the inactivated state to the closed resting state when the electrical potential difference across the cell membrane is reduced to below threshold potential. And the threshold potential for voltage-gated calcium channels is again usually around negative 55 millivolts, like it was for voltage-gated sodium channels and voltage-gated potassium channels. So what does that overall mean? That means that if we had a neuron that was using L-type voltage-gated calcium channels to produce the upstroke of its action potential instead of voltage-gated sodium channels, then Verapamil would stop those neurons from firing at all if they were firing too rapidly. So, not all neurons use voltage-gated sodium channels to produce the upstroke of their action potential. You can use voltage-gated calcium channels. Indeed, you can use L-type voltage-gated calcium channels instead for the upstroke of the action potential. And some neurons do use L-type voltage-gated calcium channels for the upstroke of their action potential. Okay? Now, those neurons which use L-type voltage-gated calcium channels for the upstroke of their action potential, they will be affected by use-dependent L-type voltage-gated calcium channel inhibitors in exactly the same way. If they are firing action potentials at a normal frequency, there will be no effect whatsoever. However, if they're firing action potentials at a far too fast frequency, they will be completely silenced, just as we discussed for use-dependent voltage-gated sodium channel inhibitors. So what this potentially suggests is that in this hyperactivity phenomenon in one side of the hypothalamus, potentially L-type voltage-gated calcium channel using neurons are important. Potentially some of these neurons that are important in here and are firing far too fast in this hyperactivity phenomenon use L-type voltage-gated calcium channels for the upstroke of their action potential rather than voltage-gated sodium channels. That would explain why Verapamil is effective at blocking the hyperactivity phenomenon from occurring in the hypothalamus by silencing those neurons when they try and fire too frequently. But it would rely on those neurons that are crucial to this hyperactivity being ones that use L-type voltage-gated calcium channels for the upstroke of their action potential rather than voltage-gated sodium channel inhibitors. Rather than voltage-gated sodium channels. Right, so Verapamil is a fantastic treatment used for the prophylactic treatment of cluster headaches, and it is reasonably effective at preventing people from suffering from cluster headaches. And it's the one that is preferred over long-term use of the glucocorticoids because, of course, if you use glucocorticoids long-term, they can lead to iatrogenic Cushing's syndrome. They can lead to big side effects. So Verapamil is usually preferred as the long-term prophylactic treatment for cluster headaches rather than glucocorticoids. Okay, and that completes our discussion of the treatment for cluster headaches. So let's just briefly summarise what we've seen. So abortive treatment, not NSAIDs and paracetamol. The best abortive treatment is 100% oxygen at a high flow rate, 7 to 10 litres per minute. That must somehow stop this hyperactivity phenomenon from occurring in the hypothalamus. Once it's started, it must terminate it. Other treatments that can be used to relieve the headache are the 5-HT1B, 1D and 1F agonists, and they're important for that 5-HT1F agonism, and those of course include the triptans and the Ergot Alkaloids, and they will work by inhibiting the second-order neurons in the trigeminocervical complex and therefore producing relief from the actual headache, even though they're not going to stop the autonomic symptoms and they're not going to stop the actual hyperactivity phenomenon that's causing the whole process. Prophylactic treatments for cluster headaches, two different types here. Verapamil is the one that's preferred long-term, which is a use-dependent L-type voltage-gated calcium channel inhibitor, and this will stop neurons from firing at all if they are firing too rapidly and they use L-type voltage-gated calcium channels for the upstroke of their action potential rather than voltage-gated sodium channels. So this suggests that maybe these neurons that are crucial for producing this hyperactivity phenomenon, maybe they use voltage-gated calcium channels for the upstroke of their action potential rather than voltage-gated sodium channels. It's just a theory. It's not scientific fact that. It's a suggestion. So, the other type of prophylactic treatment is the glucocorticoids, of which we have 6 different examples here. These, unfortunately, cannot be used long-term. Well, we don't like to use them long-term because they can give rise to serious side effects when you are activating this cortisol pathway in all the cells of your body on a regular basis at far higher levels than it should be. But of course their mechanism is they do indeed activate glucocorticoid receptors in every single cell, and therefore they result, well, most cells in the body anyway, they result in the change of gene expression all over the body, and this is probably effective at preventing cluster headaches because it will change the gene expression in cells in the hypothalamus and therefore change the behaviour and somehow then lead to them being less likely to actually develop this hyperactivity phenomenon. Okay, so that completes my discussion of cluster headaches. In the next video we will move on to discuss the secondary headaches.